Welcome back, everyone. Harshal here, and I am absolutely thrilled you're joining me today. We're jumping right into what I consider a definitive explainer on conquering the 2026 CPT E&M guidelines. If you've been feeling even a little overwhelmed by the recent updates to evaluation and management coding, you are in the exact right place. Today, we're breaking down the absolute core of your daily coding workflow, choosing how you actually level an encounter. Grab your notebooks, because we're going to make this crystal clear. Okay, let's dive into this. Here's our roadmap for today's explainer. We'll hit dual pathways, then an MDM overview, followed by the 3 elements, the time-based rules, and wrap it all up with coding strategy.
All right, kicking things off with Section 1, Dual Pathways.
So this is where every single coding encounter actually begins. Whenever you sit down to code an E&M visit, whether it's an office visit, hospital inpatient, or a nursing facility, you're immediately faced with a literal Y fork in the road. You basically have 2 distinct pathways to reach your final code: medical decision-making, or MDM, and total time spent on the date of the encounter. Your absolute first job as a coder: look at the provider's documentation and decide which of these 2 paths makes the most sense for the visit you're evaluating. So the crucial point here is that these pathways are completely 100% mutually exclusive. You cannot mix and match them for the same patient visit. No way. You can't just say, well, the MDM was low, but the doctor spent 40 minutes, so let me just mash them together to get a higher code. Absolutely not. You have to plant your flag. You select only one basis for your code selection per encounter. You're either walking down the MDM path or you're walking down the time path. It's one or the other. Moving right along to Section 2, MDM Overview. With that fundamental rule established, let's head down our first pathway. I actually really like to think of MDM as the true cognitive engine of healthcare, right? We're measuring the sheer brain power and clinical judgment the provider used to diagnose and treat the patient. The CPT guidelines categorize this cognitive effort into 4 distinct levels of complexity. It scales up really gracefully, starting at straightforward for your most minor issues, stepping up to low, escalating to moderate, and then finally peaking at high complexity for those severe, life-threatening scenarios. And the level you land on, that directly dictates your final CPT code.
Next up is Section 3, the 3 elements.
Listen closely here, coders, because this is your bread and butter. MDM isn't just some vague feeling or vibe. It's a calculated metric, and it's driven by 3 distinct elements that you absolutely must evaluate in the clinical documentation. First, what is the number and complexity of problems addressed? Like, are we dealing with 1 self-limited bug or maybe 3 worsening chronic illnesses? Second, what is the amount and/or complexity of data reviewed and analyzed? Did the provider just glance at 1 lab result, or are they ordering MRIs, reviewing external records, and consulting an independent historian? And third, what is the risk of complications or morbidity and mortality? Are we talking simple rest or major emergency surgery? Now, this is where it all comes together. This is the absolute golden rule of MDM coding. To qualify for a specific MDM level, the documentation must meet or exceed 2 out of the 3 elements we just went over. You really need to memorize this rule of 2. You do not have to hit all 3. Say you've got moderate problems and moderate risk, but only minimal data. Boom, you've met 2 out of 3. You are at moderate MDM. Nailing this rule is literally the single most vital step for your coding accuracy. And this brilliantly illustrates how those elements translate into actual real-world patient scenarios across the 4 levels. Think about straightforward. It's minimal everything across the board. But as you step up to low, maybe you see the provider managing 1 stable chronic illness. Jump to moderate, and you're typically juggling multiple problems. Maybe some prescription drug management is in the mix, which totally hits that risk element. And at high, we're talking severe life-threatening problems and major surgical risks. Basically, you look for the traits in the documentation, map them to your 3 elements, and just apply that rule of 2. All right, shifting gears to Section 4, time-based rules. So we've mastered the cognitive engine, right? Now let's explore the time pathway. This is all about utilizing the total time spent by the provider on the exact date of the encounter. Honestly, the biggest game changer in the modern E&M guidelines is the definition of countable time. It's not just the time the doctor's sitting in the exam room holding the patient's hand anymore. Countable time is the total time on the day of service. It encompasses 3 phases: pre-visit non-face-to-face work, like reviewing past tests, the actual face-to-face examination and counseling, and post-visit work, like EHR documentation or calling other providers for care coordination on that same calendar date. You just add it all up. But, and this is a massive but, the documentation constraints are incredibly strict. While the provider doesn't necessarily have to write started at 2 p.m., stopped at 2:40 p.m., they absolutely must document a single specific total time. If the chart says I spent 15 to 30 minutes with the patient, you cannot use time to level that visit. Vague ranges are an instant disqualifier in an audit. It needs to say something like I spent exactly 35 minutes today. Once you have that specific total time nailed down, you just map it to the exact CPT thresholds. Keep in mind, the minimums do differ based on patient status. For a level 3 established patient, a 99213, you need at least 20 minutes. But for a level 3 new patient, a 99203, you need at least 30 minutes. You just have to meet or exceed the absolute minimum minute listed in the threshold to assign that specific code. Now, what's really interesting about this rule is the fallback. Like, what happens if the doctor documents time, but it's super short? Well, if the documented time is less than 15 minutes for a new patient or less than 10 minutes for an established patient, you fall off the time chart entirely. You literally cannot use time. At that point, you are strictly mandated to use medical decision-making instead to choose your E&M level. Let's bring it all home with Section 5, Coding Strategy. Okay, so we know the rules for MDM, and we know the rules for time. When you get a beautifully documented note that has both a clear MDM and a specific total time recorded, I want you to look at the chart holistically. Ask yourself this one specific question. Which method best reflects the complete scope of care provided today? Because at the end of the day, your goal as a coder is to ethically and accurately capture the full extent of the provider's hard work. So here's my rapid-fire strategic breakdown to help build up that coder's instinct. If you're reading a note and you see the provider spent an extensive amount of time counseling a patient or maybe answering a million questions for the family, doing heavy care coordination, but they aren't prescribing dangerous meds or ordering a ton of labs, instinctively lean towards time-based coding. It's usually going to yield the more appropriate code there. Conversely, if the visit was maybe only 15 minutes long, but the doctor interpreted an EKG, ordered 3 labs, and started the patient on a high-risk medication for some complex diagnostic issue, rely on MDM-based coding. MDM will properly capture all that intense cognitive heavy lifting. Let's move to a few practical examples and see how this builds out in the real world. Imagine a 35-minute visit that was mostly spent on diabetes counseling. The MDM might only be low here, which is a level 3, but those 35 minutes? That pushes it to a 99214, a level 4, based on time. Scenario 2, a super fast visit, but with multiple comorbidities, lab orders, and a medication change. Time might only support a level 3, but that heavy cognitive effort pushes the MDM up to moderate, so you'd bill a 99214 based on MDM. And finally, say you have a massive 70-minute visit for a new cardiac patient with tests ordered. That total time easily rockets you up to a 99205 based on time. See how applying this strategy maximizes your accuracy? And there you have it, folks. When you master these dual pathways, really understanding exactly when to leverage the cognitive depth of MDM and when to utilize the sheer effort of total time, you are guaranteeing confident, compliant, and highly accurate E&M code selection every single time you sit down at your desk. So the next time you open up a complex patient chart, ask yourself, are you going to let the clock dictate your code, or will you let the clinical complexity do the talking? Thank you so much for joining me for this explainer. Don't forget to like, share, and subscribe to Decode Healthcare with Harshal.